We've had some very interesting talks so far about doing the work on the ground and some things that have really worked well in local practices, particularly at the moment in Luton. We've heard about 8 practices working together in Lower Lee Valley. I was very interested to note that Richard at no point did he talk about merging contracts or forcing mergers in any shape or form. He's literally talking about practices working very closely or collaboratively at the level at which they want to. And I want that theme to start to come out a little bit, that this is very much about your choice and the choices you make for the future. I'm delighted to introduce our next speaker, Steve Laitner. Steve and I have known each other for a good few years now, and Steve has been leading the way in a number of innovations. Steve is also a GP working in St Albans on a regular basis, but perhaps not full time because he's so engaged in so many other things. So welcome, Steve. Steve's going to introduce you to Primary Care Home for those that haven't heard it, and what opportunities lies with Primary Care Home. Steve, over to you. I'll leave the glasses on the table.
Thank you very much, Peter, and it's a pleasure to talk to you all. To try and keep you from your post-lunch soporific stupor, I will try and make this engaging and interesting, and gives me an excuse to be overexcitable, as I tend to be about these sorts of things. So the flavour of the day really has been about optimism and making the changes that are necessary. And I think that's absolutely right. I do a couple of sessions in general practice. I've been a part-time salaried GP for many years because I've had a career in public health and now freelance consulting. And I think part of the reason for that is because general practice is bloody hard. I do a couple of half days a week. I tend to, on the morning, I finish about 3 o'clock or 2:30, and when I do an afternoon, maybe finish about 7:30. So to think that people are doing that, 4 days a week or more full time, it's incredibly hard. And I think what we know is, and what has been highlighted in the front page of the document, is to make that sustainable and to improve our working lives and to also deliver better care to patients, we need to work differently. And I think it's difficult, it's possible, but it's difficult for individual practices to have the headspace and the scale to deliver the sorts of changes that are required, which is why I've been so excited by the primary care home model. Do tweet, I'm at Steve Laitner, so do let me know what is interesting and what is not interesting in the conversation. So I joined the National Association of Primary Care, which is a model to help practices work together to improve their working lives and to deliver better care to their patients. And what is it? Well, it's an integrated provider model. It's about people working together to deliver care better. It's focused on a defined population, and I'll come on to describe the size of that population. It's about 30 to 50,000, which we feel is about the right size to do this. Other things will be done at other levels, at the individual practice level and at levels above that. But 30 to 50,000 seems to be about the right size to deliver most primary care functions. It's founded on and builds on the strength of general practice and the registered list. But as well as having responsibility for the delivery of individual patient care, it also has a population responsibility and accountability as well. Obviously, you as GP practices do as well, but this becomes more defined around that larger population, and that allows you to work with others in that population health space. By a primary care home, we don't mean a care home. What we mean is the home of care for a population where most care takes place, and that's why primary care is essential as the foundation for this. And we go for a sort of Goldilocks principle. We think that an individual practice is probably a bit small, or to think in Goldilocks terms, a bit hot to do these sorts of things. And a federation or a CCG or an STP level is a bit large or a bit cold. but about 30 to 50,000, which is about the size of quite a lot of natural communities, and it has a workforce of about 100 to 150, the evidence is that that is the right size. It's not too small, so you can't care, but it's not too big, so you lose the caring and the individual nature and continuity, but it's also not too small, so it allows you to scale. So it's focused on 30 to 50,000 people. It's about a multidisciplinary integrated workforce, which isn't just medical and isn't just primary care. It's about the specialists that we heard Chris Ham talked about. It's about community, people from community care. It's about mental health workforce. It's about clinical pharmacists, paramedics, local voluntary sector organisations. It's about a dream team of people to manage the needs of that population. And it's about aligning the financial incentives. So what we know at the moment is that although most care takes place in primary care actually gets a fraction of NHS spending, as you all know, and that's been decreasing over time. So if we get primary care right and primary care home right and we deliver more care, it's a vehicle to allow that funding to move from hospital funding into primary care. And that has to happen, but we need to be that change. We need to make that happen. So this is looking at traditional state where most care goes through a GP and then there's a referral rate onto other people. With the primary care home model, the GP is one of the workforce that is able to meet the needs, meet the demand that's flowing into it. Like you were hearing from the Luton practice this morning, we try and streamline care so that the GPs see people that only they should see, whereas we have social care, third sector, mental health specialty care, and the GP is part of that broader team, and the primary care home gives you the scale to enable you to do that. So what are the advantages from a workforce perspective? Well, it gives you resilience. It enables you to work together to support each other, and where individual practices have been struggling, we've seen other practices come together to support that practice. There's about 190 primary care homes across the country now. Richard from Lee Valley, you heard from this morning, they're due to join us, and there's quite a few others around Hertfordshire, in Bedfordshire, in Milton Keynes, and quite a few in London now. So we're growing, and what we've seen is it gives resilience, it gives flexibility, which I'll come to, so people can do the things they love to do, or perhaps do less of the things they don't like to do. It's about working in teams, and we talk about teams and squads. So there might be a team for the whole primary care home to manage the whole population needs, but you might have a squad of people that are focusing on same-day access, or frail elderly, or young people with mental health problems. So you don't have a one-size-fits-all approach, which general practice traditionally had. Better alignment of roles and functions, and the idea is it will not only deliver better care, because we know teams, integrated care continuity does deliver better care, but it allows us to have a better work-life balance and allows more funding over time to move to primary care because we're doing more. So just to change the focus a little bit now, but we must be rooted in the fact that one of the big reasons we're doing this is to support you as practices to manage the increasing demands that you're facing. And from what we've seen of the primary care homes to date, it has given you headspace and it has enabled you to do the things you perhaps struggle to do on your own. But when we're designing care, when we're designing what our offer is to our patients, I suggest the Steve's Jobs approach, which is not to start from a general practitioner perspective or a practice manager perspective or a GP practice or a hospital perspective, but to start with what are people actually after? Why are they calling us in increasing numbers? What do they want from us and how do we meet their needs? And actually going further than that, how do we anticipate what their needs might be? So thinking about Steve Jobs and the iPad, a lot of people at the time said, oh, no one's going to want the iPad, it's just a jumped up iPhone. But Steve Jobs had the insight that actually if given that larger piece of technology, people will want to press the button and do things that way. So we, many years ago, because I've had the headspace to think about doing things differently, we introduced telephone triage to our practice. We heard about that this morning as well. A lot of patients at the time would say, but I just want to see the doctor. But actually, when you introduce it and when you explain to people, they can see the doctor if that's necessary, but actually people appreciate speaking to somebody on the phone or seeing a member of staff. So this is often the lens that we have in the NHS. We think about the world through the eyes of the practitioner, through the eyes of the producer, the provider of care. But actually, if we take a step back and we really think and we work with our patients and patient participation groups and patient leaders to find out what is it they're actually after, then we come to a different conclusion, and that's the place to start. So I have many calls with patients now when I'm doing triage in my practice, where at the end of it, for example, the mother concerned about her child with a fever, or actually she's not concerned, she's just been given grief by her husband to ring the practice because he wasn't happy with what was going on. Then at the end of the conversation, the patient says, actually, that's all I wanted. I wanted some reassurance, some information, some advice. And there's really good evidence that as healthcare providers, as doctors, we overestimate what patients want. We think they want a prescription when often they don't. We think they want a referral more often than they say they want it. So part of the flavour from this morning is putting form after function. But I think there's another F to start with, and that is focus. What are you going to, in your primary care home, what are you going to focus on? Because it's probably difficult to start with the needs of 50,000 people, because it's very varied and very big. But you might say, actually, we're really struggling with our frail elderly population, with our young people with mental health problems, with our urgent care of people who are generally well, with our long-term condition management. So choose what you're going to start with and what you're going to focus on. Over time, you'll be looking after the whole population, as you already are, but in a different way. But start with some areas to focus on where it's not working for you, it's not working for your patients. Then think about not new models of care, which has come to mean new organisational forms, but new models of caring. How are we going to deliver care differently to meet the needs of that group that we're focusing on? And then what new organisational forms may or may not be required. So one of the big things that's attracted me to the primary care home is that, as Peter said, there's no new organisational form required at all. It's just about people working together, working with their local partners. It doesn't need a new legal entity. It doesn't need a new contract. It's just people working together. And then funding obviously needs to flow in the right way. At the heart of a primary care home is population health management. And I used to work as a public health consultant and was involved in joint strategic needs assessment, but it's not assessing the needs of the population in an academic way. It's actually assessing the needs of the population in a really practical way where you're going to offer certain types of care to different patient groups and cohorts. It's about cutting the cake. It's about segmenting your 150,000 people into manageable chunks where you're going to offer different types of care to make their lives better, but as importantly, to make your lives better as well. And our primary care homes, I'll just keep looking at this to see how long I've got to leave time for questions at the end of the two talks. So our primary care homes are focusing on similar areas. So a lot are focusing on people who are generally well, who have urgent care needs, where actually if we come back to the question, the first question I think after the presentations this morning, is actually continuity isn't always necessary. For some people it's absolutely essential, like people with complex problems, with comorbidities, with frailty. Continuity is absolutely critical then, and for people at end of life. But for a 24-year-old with acute tonsillitis, for a 5-year-old with otitis media who's otherwise well, actually continuity isn't important, and neither clinically nor for the patient. So we might think about people who are generally well, we might think about frail older people. There's lots of different groups in society where we're probably not meeting their needs as well as we could do as a practice, and we're also consuming a lot of our time trying to meet those needs that could be done better at a larger scale with a different workforce across practices. So we developed in the National Association of Primary Care, I led this with a colleague of mine called Mark Davies, what's a really simple population grid to think about the different needs of people in our population. So we think about people who are generally well. By that we mean an absence of a long-term condition. Very happy to make all these slides available, so don't worry about writing it down or taking photos, but you can if you like. So people who are generally well, people who have long-term conditions, and it might be more than one long-term condition, who are reasonably well managed. They're not complex, they're not frail, they've maybe got a bit of hypertension, some asthma, maybe some mild depression, but they've got a plan and they're carrying on their lives and things aren't too tricky. But then there are people who are really complex. So frail older people with dementia, depression, cancer, end of life. Working age adults who are out of work, single parent, schizophrenia, etc., etc. So you've got 30 to 50,000 people to look after with your colleagues and neighbours. You're in a natural community. There's not one model of care for 30 to 50,000 people because there's different needs out there. So there's not 30 to 50,000. There's not one model of care, but nor are there 30 to 50,000 models of care. So we can't have an individual model of care for everybody. Whilst we will be treating people as individuals, we can think about segments, cohorts, people with similar needs that we're going to build teams around them to meet their needs. So we might have people with individual conditions that are suitable for our cardiovascular clinic or our asthma clinic. We'll also have people with a number of long-term conditions where we actually need a sort of comorbidity clinic wrapped around their needs. And then there's people who are complex, where we need a much more integrated team of people with volunteers, with social prescribing expertise, with clinical pharmacists, with paramedics perhaps for home visiting. We need to think about the different life courses in society, children, young people, working age adults and older people, and then the different levels of need, and begin to think about those groups separately and wrap services around them. We then maybe get into looking at the clinical conditions that those people have, and people who are currently generally well but at risk of tipping over long-term conditions because they've got a number of risk factors. And then the other way of looking at it, and we're sort of nearly finishing slightly ahead of time, is that you've got the sort of 2x2 matrix around life course and, in a way, intensity or complexity of need. And then you've also got different types of need. You've got ongoing care needs. So that can be for people who are generally well, that can be child health surveillance, it can be vaccination and immunisation and screening. And for people with long-term condition, it's going to be their self-management support is an ongoing need, their care planning needs. And then you've got urgent care needs, because any of these groups can become acutely unwell. But we might have a slightly different response to that urgent care need depending on what is required. Okay, so I have got a few more slides which will just about take us to time. This is an example of a population segmentation approach I've been doing with a group called Carnell Farrer in Kent and Medway, where they've got something called the Kent Integrated Data Set, which is a linked data set across all the providers in Kent and Medway. So we're able to find the people who are older with complex needs. And what we've done there is a sort of submarine approach where we've taken people over 70, who are anything but healthy, but we've also taken people with dementia who are in the working age adult age group. And we've designed a model of care particularly around that cohort, which I shall show you. So what we've designed, we've based it around somebody called Dorothy, who is 79, frail, has diabetes, COPD, some cognitive impairment and depression. And we've designed a multidisciplinary team, a dream team of people who will be wrapped around her needs. It will include her GP and a GP with a stress special interest, and it will include the geriatrician and the psychogeriatrician, but it will also include a peer support worker, a clinical pharmacist, a care navigator, somebody who follows the patient into hospital and helps with the discharge. So we focus on a group of the population, and for a primary care home this will typically be about 1,300 people, and we pull a team together, a virtual team, but they will meet regularly as well. So they happen to be hosted, they're employed by different organisations, but that doesn't matter. They will have a list of 1,300 people that they will actively manage, proactively, but also they will respond to their urgent needs, because these people do need continuity. They don't need to speak to any doctor who happens to be the duty doctor in the practice that day. They need to speak to people who really know them and their holistic needs and can draw on all these different functions, both in the team and the supporting functions around them. So this was a model I developed a while ago, which suggests the sort of streaming we might be able to have in primary care, where on the far left you've got a load of demand, probably about half the demand, same day demand, where continuity really isn't important. It's about assessing the needs, signposting off to dentistry, to minor injuries through good call handling, and then having good senior experienced clinical triage that can manage probably about 60% on the phone, because a lot of medicine, as we know, about 80% of diagnoses can be made on a history alone, and then seeing people face to face who need to be seen. Then there's a group of people who aren't really complex but do need continuity, and that's a similar sort of approach, but it might be a particular clinician calling them back and a particular clinician seeing them. And then you've got the really complex people where actually we need as much proactive care, probably more outbound calls and proactive care as much as reactive, and we need absolutely continuity of care in a team of people wrapped around their needs. So that's actually the end of the talk. We are still open for expressions of interest from groups of practices who want to work together, covering a population of about 30 to 50,000, and we will be able to support you in that journey to improve your working lives and also to improve the care that your patients are receiving. So hopefully that has been helpful, and I'll be happy to take questions afterwards. Thank you.